Does every traumatic hemorrhage need a repeat CT? Welcome back to the AJNR Podcast. My guest today is Dr. Caline Azzi, my colleague on the faculty at Johns Hopkins. She's an emergency neuroradiologist and assistant professor. She is the senior author of an article in the August issue of the AJNR about predictive factors for traumatic intraparenchymal hemorrhage expansion and its clinical outcomes. The first author is Dr. Mona Gad, our research fellow at Hopkins and also former junior editor for the AJNR. But we're not just going to talk about that one article. It turns out that Caline and collaborators, including Dr. David Usum, have developed a whole body of research on traumatic intracranial hemorrhage expansion prediction, including an article published in the AJNR in February 2026 on subarachnoid hemorrhage, and another published in Emergency Radiology in 2025 on subdural hematomas. Welcome, Caline.
Hi, Francis. Thank you for having me here.
Your studies address a simple question, if I can boil it down. Can we identify which patients truly need a repeat CT after an initial post-traumatic CT has identified a hemorrhage? Say an older patient falls from ground level and CT shows a small traumatic subarachnoid hemorrhage over the cerebral convexities. And so the patient is observed in the ED and a repeat CT is obtained a couple of hours later, 6 hours later. And that's probably a substantial portion of our volume as neuroradiologists these days. So what motivated you to study routine follow-up imaging with various types of traumatic hemorrhage?
So that's exactly the question we wanted to answer. Repeat CT has become routine in many trauma pathways, yet many follow-up scans remain stable and don't really change management. We also found considerable variability in who receives repeat imaging. So our goal was to identify objective clinical and imaging features that distinguish low risk from high risk patients, so that follow-up CT can be guided by risk rather than a one-size-fits-all approach. Ultimately, we hope that this can improve patient care while reducing unnecessary imaging and resource utilization.
Let's talk about the structure of these studies in broad strokes. Why did you study these hemorrhage types differently, and how did you design the studies?
So, although all three are traumatic intracranial hemorrhages, they behave differently. So we studied each compartment separately. We used the same retrospective design across two hospitals, evaluating clinical and imaging features associated with hemorrhage enlargement and neurosurgical intervention. It allowed us to identify both hemorrhage-specific predictors and common themes across all three studies.
It's worth emphasizing that this is a retrospective design, and we're trying to identify risk factors for hemorrhage expansion, try to separate out high-risk folks and low-risk patients. It was not a prospective trial of seeing who you could withhold imaging on, right?
Yeah, exactly. So that's an important point. These studies were never intended to suggest that repeat CT should be omitted based on these findings alone, but they identify imaging and clinical features that consistently distinguish lower risk versus higher risk patients and provide a foundation for future prospective validation. Ultimately, our goal was to develop evidence-based decision tools that can safely guide follow-up imaging, but those tools will need to be validated before they can change clinical practice.
Let's dig into the subdural hematoma paper. What were your main findings?
So, among patients who underwent follow-up imaging, approximately a quarter had some enlargement. A larger initial hematoma size, associated subarachnoid hemorrhage, midline shift, were among features that were associated with enlargement. And we noticed that subdural hematomas measuring less than 3 millimeters in thickness never required surgery, and an initial thickness of more than or equal to 8.5 millimeters predicted surgery.
The small subdural hematomas were pretty interesting to me. Some of them had enlarged, but yet none of them ultimately required surgery. So how should readers, fellows, practicing neuroradiologists interpret that distinction?
So that's an important distinction, and radiographic enlargement basically does not necessarily translate into clinical deterioration or a need for intervention. In our cohort, some subdural hematomas measuring 3 millimeters or less did enlarge slightly, but none require surgery. And this suggests that not every measurable increase on follow-up CT is clinically meaningful, and that management decisions should always be interpreted in the context of the patient's neurological exam and overall injury pattern.
Do you think we're ready to use 3 millimeters clinically as a cutoff to determine who does or does not need repeat imaging?
I would be cautious about using 3 millimeters as a definite cutoff. So our findings do suggest that subdural hematomas measuring 3 millimeters or less represent a very low-risk subgroup, but this was a retrospective single-center study. The observation is promising and should be prospectively validated before being incorporated into clinical guidelines.
You mentioned a couple of predictors other than size. Can you go over what those were?
Right. So size was important, but it wasn't the only predictor. Concurrent traumatic subarachnoid hemorrhage, midline shift, hypertension, and convexity location were also associated with enlargement. This reinforces that risk assessment should integrate both imaging features and the overall clinical context rather than relying on size alone. And something we did notice is that tentorial presentation, these tended to not really increase in size or require any intervention.
Finding that I found interesting in this paper was whether anticoagulation or antiplatelet therapy was a significant predictor of enlargement. And if I recall correctly, you found that it was not really a significant predictor. Can you go over that?
Yeah. In our study, antiplatelet and anticoagulation use were not independent predictors of enlargement after multivariable analysis. While coagulopathy remains clinically important, of course, imaging features such as hematoma size and associated injury patterns appear to provide a stronger prognostic information in this cohort.
Right. So that was subdural hemorrhage. Now let's talk about subarachnoid hemorrhage. What were the main findings in your paper about traumatic SAH?
So in our SAH paper, only 18% of the subarachnoid hemorrhage enlarged on follow-up CT. The major predictors of enlargement were lower Glasgow Coma Scale, elevated AJNR PTT, and coexistent intraparenchymal hemorrhage. So coexistent intraparenchymal hemorrhage did not remain statistically significant after multivariable adjustment. The initial subarachnoid hemorrhage size alone was not a strong predictor of enlargement. This suggests that the overall injury pattern and clinical status are more important than the exact amount of subarachnoid blood in isolation.
So given that multiple different types of predictors were important, how would you suggest our listeners think about this overall fitting into a clinical decision algorithm? How much should the neurologic exam drive the decision to repeat imaging?
The neurologic exam should definitely play a central role. The imaging findings are important, but repeat CT should always be interpreted in the context of the patient's clinical trajectory. A stable patient with an isolated low-risk subarachnoid hemorrhage may not require the same imaging strategy as a patient with worsening neurological status or additional high-risk features.
I want to take this chance to go on a little bit of a tangent here because your SAH study also addressed a separate but related issue, which is getting CTAs. And the clinical scenario that we not infrequently encounter is that the patient comes in with trauma, they're found to have a subarachnoid hemorrhage. But the question is, was that subarachnoid hemorrhage the result of their trauma and hitting their head, or was the subarachnoid hemorrhage the trigger for them falling or causing themselves to get into a car accident? What are the situations that we might consider getting a CTA or recommending a CTA for these individuals who have a subarachnoid hemorrhage and prior trauma?
That's a very important question. In our patients with subarachnoid hemorrhage and clear antecedent trauma, 46% had a CTA obtained. Of those, 10% had an aneurysm, which was then considered related to the trauma presentation. All of these patients did have basal cisternal involvement and intraventricular hemorrhage and hydrocephalus. The patients was also unable in these settings to give a clear medical history, so also that is relevant.
When do you think a apparent traumatic SAH should prompt CTA, just to put a different angle on that question?
So not every apparent traumatic subarachnoid hemorrhage is truly traumatic. CTA should be considered, I would say, when there is basal cisternal subarachnoid hemorrhage, intraventricular hemorrhage, or hydrocephalus, or if there is an unclear mechanism of injury, the patient cannot provide history. In those cases, it does raise suspicion for aneurysmal subarachnoid hemorrhage, and CTA may be worth it.
And likewise, do you think we are able to forego or recommend against getting a CTA if a patient only had isolated convexity subarachnoid hemorrhage and a clear history of antecedent trauma?
So according to our study, yes, we did find that the patients who did have aneurysmal related subarachnoid hemorrhage, all of them had basal cisternal hemorrhage, hydrocephalus. It was none of the patients with just isolated cerebral convexity subarachnoid hemorrhage.
So now let's move on to your most recent paper on traumatic intraparenchymal hemorrhage, which I guess includes hemorrhagic contusions and perhaps some hemorrhagic shear injuries as well. What were your major findings?
So in our intraparenchymal hemorrhage study, 30% of intraparenchymal hemorrhages enlarged on follow-up CT. Enlargement predictors were mainly the initial size and whether there was also associated subarachnoid hemorrhage. Interestingly, isolated intraparenchymal hemorrhages measuring less than 5 millimeter neither enlarged nor required surgery.
So we teach that blossoming is pretty common with contusions, and your finding of 30% enlargement on follow-up CT kind of fits with my personal experience. Were you at all surprised by the low risk of the small, isolated intraparenchymal hemorrhages?
Yeah, actually we were. We expected some degree of contusion enlargement, but one of the most reassuring findings was the isolated less than 5 millimeter intraparenchymal hemorrhages not enlarging or requiring surgery. So this suggests that even within contusions, the risk is heterogeneous, and the smallest isolated lesions may represent a very low-risk subgroup.
Now you found that associated subarachnoid hemorrhage identified a more high-risk injury phenotype. Why do you think that might be?
I think that just the fact that there is associated subarachnoid hemorrhage reflects a more severe traumatic insult rather than simply an additional hemorrhage compartment. It may indicate greater force of injury causing both more diffuse damage, which could explain why the patients with both intraparenchymal hemorrhage and subarachnoid hemorrhage were more likely to experience enlargement. Our study identified coexisting subarachnoid hemorrhage again as an independent predictor for enlargement, probably due to those reasons.
Paper had a receiver operating characteristic curve that plotted size against the ability to discriminate hemorrhage enlargement when it came to intraparenchymal hemorrhages, but it was a pretty weak discriminator. What do you think that tells us about how a decision tool should be built around this idea?
It basically suggests that no single imaging feature is sufficient. While a hemorrhage size is important, it should be interpreted again alongside other findings and the patient's clinical picture, including associated hemorrhages, neurologic status, coagulopathy. A practical decision tool will likely need to integrate these multiple variables rather than rely on a single size threshold.
So let's talk across all three papers. Would you say that the hemorrhage compartment is less important than the overall clinical and imaging phenotype?
The compartment still matters, but the broader phenotype appears more useful for risk stratification. Across SDH, SAH, IPH, higher risk was consistently associated with features such as larger hemorrhage burden, multicompartment injury, mass effect, coagulopathy, and a worse neurologic exam. So the decision to repeat CT should not be based on the hemorrhage type alone.
And what findings would make you uncomfortable omitting repeat CT?
So I would be uncomfortable omitting repeating CT in a patient with a larger hemorrhage, like an initial larger hemorrhage, multi-compartment injury, midline shift, or some kind of mass effect, abnormal coagulation, or a low declining Glasgow Coma scale. Interval neurologic symptom development, skull fracture, intraventricular hemorrhage, hydrocephalus, or limited ability to monitor the patient would also favor a closer surveillance.
So it sounds like we can start formulating in our mind a scoring system or a decision tree of some sort. And in your SAH paper, you and your co-authors proposed a practical algorithm for clinicians to determine imaging-related management. Could you walk us through that algorithm?
Sure. So the algorithm combines the imaging and clinical features to stratify patients into a low, moderate, and high-risk groups. Low-risk patients with isolated traumatic subarachnoid hemorrhages and a stable neurologic exam may only require observation. Moderate risk patients may benefit from an early repeat CT, while high-risk patients, such as those with a low GSS, midline shift, larger associated hemorrhages, or severe coagulopathy, those require closer imaging surveillance and neurosurgical evaluation. Importantly, this is a proposed framework. It still requires prospective validation.
What would that prospective kind of study look like before we can confidently implement and disseminate such a tool?
So the next step would be a prospective multicenter validation study enrolling consecutive patients with traumatic intracranial hemorrhage. The proposed tool would be applied at the initial CT, but management would still initially remain based on usual care. We would then measure how accurately the tool identifies patients who can safely avoid repeat imaging and whether it performs consistently across different hospitals and patient populations.
And what's the outcome that we should be focused on, the clinical outcome that we would address through a prospective study?
So the primary outcome should be a clinically meaningful safety outcome, most importantly. Missed neurosurgical intervention or clinically significant neurologic deterioration, not simply just enlargement on CTs. The length of stay, imaging utilization are important secondary outcomes, but reducing scans only matters if the patient's safety is preserved.
Fantastic, Caline. I'm so glad that you were able to come on the podcast today to discuss your papers. What takeaways do you have for our listeners?
So these studies suggest that the default pathway of repeat CT for every traumatic intraperineal hemorrhage deserves reconsideration. The next step is a prospectively validated tool, like I said, that identifies patients at sufficiently low risk to avoid routine imaging while preserving close clinical monitoring for those who need it.
Thank you so much for joining us today, Caline.
Thank you, Francis. Thanks for having me.
I've been speaking with Dr. Caline Azzi on the AJNR Podcast. You can check out the show notes for links to all 3 articles. Until next time.